Hi everyone, welcome in my YouTube channel. Today let's talk about the respiratory system.
Normal structure of lungs. Developmentally, the respiratory system is an outgrowth from the ventral wall of the foregut. The midline trachea develops two lateral outpouchings, the lung buds. The right lung bud eventually divides into three main bronchi, and the left into two main bronchi, thus giving rise to three lobes on the right and two on the left. The main bronchi branch dichotomously, giving rise to progressively smaller airways, termed bronchioles, which are distinguished from bronchi by the lack of cartilage and submucosal glands within their walls. Additional branching of bronchioles leads to terminal bronchioles. The part of the lung distal to the terminal bronchiole is called an acinus. Pulmonary acini are composed of respiratory bronchioles that proceed into alveolar ducts, which immediately branch into alveolar sacs, the blind ends of the respiratory passages, whose walls are formed entirely of alveoli, the ultimate site of gas exchange. The alveolar walls consist of the following components, proceeding from blood to air: the capillary endothelium and basement membrane, the pulmonary interstitium, composed of fine elastic fibers, small bundles of collagen, a few fibroblast-like cells, smooth muscle cells, mast cells, and rare mononuclear cells. Alveolar epithelium, consisting of a continuous layer of two principal cell types, flattened, plate-like type I pneumocytes covering 95% of the alveolar surface, and rounded type II pneumocytes. The latter synthesize pulmonary surfactant and are the main cell type involved in repair of alveolar epithelium after damage to type I pneumocytes. A few alveolar macrophages usually lie free within the alveolar space. In the city dwellers, these macrophages often contain phagocytosed carbon particles. Lung diseases can broadly be divided into those affecting the airways, the interstitium, and the pulmonary vascular system. This division into discrete compartments is, of course, deceptively simple. In reality, disease in one compartment often causes secondary alterations of morphology and function in others. Function of lungs. 1. The primary functions of lungs are oxygenation of the blood and removal of carbon dioxide. 2. The respiratory tract is particularly exposed to infection as well as to the hazards of inhalation of pollutants from the inhaled air and cigarette smoke. 3. There exists a natural mechanism of filtering and clearing of such pollutants through respiratory epithelium, tracheobronchial lymphatics, and alveolar macrophages. Besides, the lungs are the only other organ after heart through which all the blood of the body passes during circulation. 4. Therefore, cardiovascular diseases have serious effects on the lungs, and conversely, diseases of the lungs which interfere with pulmonary blood flow have significant effects on the heart and systemic circulation. Atelectasis. Definition. Atelectasis in the newborn are primary atelectasis as defined as incomplete expansion of a lung or part of a lung, while pulmonary collapse or secondary atelectasis is the term used for reduction in lung size of a previously expanded and well-aerated lung. Obviously, the former occurs in newborn whereas the latter may occur at any age. On the basis of the underlying mechanism and the distribution of alveolar collapse, atelectasis is classified into three forms. Resorption atelectasis occurs when an obstruction prevents air from reaching distal airways. Any air present gradually becomes absorbed, and alveolar collapse follows. The most common cause of resorption collapse is obstruction of a bronchus. Resorption atelectasis most frequently occurs postoperatively due to intrabronchial mucus or mucopurulent plugs, but also may result from foreign body aspiration. Bronchial asthma, bronchiectasis, chronic bronchitis, or intrabronchial tumor, in which it may be the first sign of malignancy. Compression atelectasis is usually associated with accumulation of fluid, blood, or air within the pleural cavity. A frequent cause is pleural effusions occurring in the setting of congestive heart failure. Leakage of air into the pleural cavity pneumothorax also leads to compression atelectasis. Basal atelectasis resulting from a failure to breathe deeply commonly occurs in bedridden patients, in patients with ascites, and during and after surgery. Contraction atelectasis or cicatrization atelectasis occurs when local or diffuse fibrosis affecting the lung or the pleura hamper lung expansion. Atelectasis, except when caused by contraction, is potentially reversible and should be treated promptly to prevent hypoxemia and superimposed infection of the collapsed lung. Morphology. Grossly, the lungs are small, dark blue, fleshy, and non-crepitant. Microscopically, the alveolar spaces in the affected area are small with thick interalveolar septa. The alveolar spaces contain proteinaceous fluid with a few epithelial squamous and meconium. Scattered aerated areas of the lung are hyperinflated, causing interstitial emphysema and pneumothorax.